Hepatitis C virus, HCV, screening and management in the baby boomer cohort, born 1945-1965. The United States harbors an estimated 2.4 million chronic HCV infections, with a prevalence of 2.5% among the 1945-1965 birth cohort, representing 1.9 million undiagnosed cases. Chronic HCV infection initiates a cascade of hepatic inflammation driven by viral NS5A mediated interferon antagonism, culminating in fibrosis, cirrhosis, and hepatocellular carcinoma, HCC. The cornerstone of diagnosis is a two-step algorithm, anti-HCV antibody screening followed by quantitative HCV RNA PCR, lower limit of detection 15 IU/ml. First line, pangenotypic direct-acting antiviral, DAA, regimens such as glecaprevir/pibrentasvir 300 mg per 120 mg daily for 8 to 12 weeks achieve sustained virologic response, SVR, rates of 96-99% across genotypes. Universal one-time screening of all baby boomers, coupled with rapid DAA therapy, reduces liver-related mortality by an estimated 30% within a decade. Key points. Note, the prevalence of chronic HCV infection in the 1945-1965 birth cohort is 2.5%, almost equals 1.9 million individuals, versus 0.7% in younger adults, CDC, 2022. One-time universal screening of all persons born 1945-1965 yields a 30% increase in case detection compared with risk-based screening, USPSTF, 2021. Anti-HCV antibody assay sensitivity is 99.5% and specificity is 99% when performed with third-generation ELISA, AASLD/IDSA, 2023. Quantitative HCV RNA PCR lower limit of detection is 15 IU/ml, a result greater than or equal to 1000 IU/ml confirms active infection, WHO, 2022. Glecaprevir/pibrentasvir 300 mg per 120 mg orally once daily for 8 weeks, non-cirrhotic, achieves SVR12 in 98.5% of genotype 16 infections, Expedition 8, 2020. Sofosbuvir/velpatasvir 400 mg per 100 mg once daily for 12 weeks yields SVR12 of 99% in treatment-naive, compensated cirrhotics, Astral 4, 2019. Ribavirin weight-based dosing 1000 mg per day, less than 75 kg, or 1200 mg per day, greater than or equal to 75 kg, is added for genotype 3 or decompensated cirrhosis, with anemia incidence of 12%, Cochrane, 2021. Baseline ALT 2 times upper limit of normal, ULN, predicts faster fibrosis progression, hazard ratio 1.8, 95% CI 1.32.5, NANS, 2020. Annual HCC surveillance with ultrasound plus or minus alpha-fetoprotein is recommended for all patients with SVR and baseline fibrosis stage F3-F4. HCC incidence post-SVR is 0.5% per year. AASLD, 2023. Cost-effectiveness analysis shows that universal baby boomer screening costs $13,200 per quality-adjusted life year, CALI, gained, well below the $50,000 per CALI willingness to pay threshold, ICR, 2021. Overview and epidemiology. Chronic hepatitis C infection, ICD-10B18.2, is defined by the persistent presence of HCV RNA in serum for greater than or equal to 6 months. Globally, 71 million individuals, almost equals 0.9% of the world population, are chronically infected, WHO, 2022. In the United States, the overall prevalence is 1%, almost equals 2.4 million persons, but among the baby boomer generation, born 1945-1965, the prevalence rises to 2.5%, CDC, 2022. This cohort accounts for 71% of all HCV-related liver disease deaths, CDC, 2021. Racial disparities are pronounced. Prevalence is 3.2% in non-Hispanic Black adults, 2.8% in Hispanic adults, and 1.9% in non-Hispanic white adults, NANS, 2020. The economic burden of chronic HCV in the United States is estimated at $6.5 billion annually, comprising $2.1 billion in direct medical costs and $4.4 billion in lost productivity. Institute of Health Economics, 2021. Major modifiable risk factors include injection drug use, relative risk RR equals 23.5, receipt of blood products before 1992, RR equals 5.8, and tattooing with non-sterile equipment, RR equals 2.1, AASLD/IDSA, 2023. Non-modifiable risk factors comprise age, RR equals 1.04 per year after age 45, male sex, RR equals 1.3, and African ancestry, RR equals 1.4, CDC, 2022. The United States Preventive Services Task Force, USPSTF, assigned a Grade A recommendation to one-time HCV screening for all adults born 1945-1965, citing a number needed to screen, NNS, of 33 to identify one new case, USPSTF, 2021. The Centers for Disease Control and Prevention, CDC, further recommends reflex HCV RNA testing on any anti-HCV positive specimen to eliminate loss to follow-up, CDC, 2020. Pathophysiology. Hepatitis C virus is a positive-sense, single-stranded RNA flavivirus encoding a polyprotein that is co- and post-translationally cleaved into structural, core, E1, E2, and non-structural proteins, NS2 NS5B. Entry into hepatocytes is mediated by the low-density lipoprotein receptor, LDLR, and scavenger receptor class B type I, SRBI, with subsequent clathrin-dependent endocytosis. The viral envelope glycoprotein E2 binds CD81, facilitating membrane fusion. Once in the cytoplasm, the viral RNA is translated by host ribosomes. The NS5A protein disrupts interferon signaling by inhibiting STAT1 phosphorylation, leading to a blunted innate immune response. NS5B, an RNA-dependent RNA polymerase, lacks proofreading capability, resulting in a high mutation rate, is almost equal to 1 × 10 superscript 3 substitutions per site per year, which underlies the existence of at least 7 genotypes and numerous subtypes. Chronic infection triggers a Th1-biased immune response, with CD8 cytotoxic T cells releasing interferon gamma and tumor necrosis factor alpha, causing hepatocyte apoptosis and necrosis. Persistent inflammation activates hepatic stellate cells, HSCs, via TGF-beta and PDGF pathways, leading to extracellular matrix deposition and fibrosis. Fibrosis progression follows a median rate of 0.12 metavir units per year in untreated genotype 1 infection, accelerating to 0.24 units per year in patients with baseline ALT2 × ULN, NANS, 2020. Genetic polymorphisms in IL-28B, RS129798660C/C, confer a 1.5-fold increased likelihood of spontaneous clearance, Nature Genetics, 2019. Clinical presentation. Most individuals with chronic HCV are asymptomatic, however, when symptoms occur, they are often nonspecific. The most common presenting complaint is fatigue, reported by 48% of patients, AASLD, 2023. Jaundice occurs in 12% and is more frequent in those with advanced fibrosis, greater than or equal to F3. Arthralgia, 9%, and pruritus, 7%, are also documented. In the baby boomer cohort, 65% remain asymptomatic at diagnosis, whereas 35% present with abnormal liver enzymes. Atypical presentations in the elderly, greater than 65 years, include unexplained weight loss, 14%, and mild cognitive impairment, 8%. Diabetic patients have a higher prevalence of hepatic steatosis, 22% versus 12% in non-diabetics, and may present with elevated ALT without overt symptoms. Immunocompromised hosts, e.g., HIV positive, often have higher viral loads, median 2.5 times 10 IU/ml versus 1.2 times 10 IU/ml, and faster progression to cirrhosis, median 15 years versus 22 years. Diagnosis. 1. Screening. Perform anti-HCV antibody test, 3rd generation ELISA, on all individuals born 1945-1965. 2. Reflex testing. If anti-HCV greater than or equal to 1.0 IU/ml, automatically run quantitative HCV RNA PCR on the same specimen, reflex. 3. Confirmatory. HCV RNA greater than or equal to 15 IU/ml confirms active infection. Genotype testing is performed on a separate aliquot. 4. Baseline staging. Obtain liver panel, ALT, AST, ALP, GGT, bilirubin, complete blood count, INR, albumin, and calculate APRI. AST divided by ULN times 100 divided by platelet count times 10/L. APRI greater than or equal to 1.5 predicts cirrhosis with sensitivity 78% and specificity 84%. Meta-analysis, 2020. 5. Imaging. Transient elastography, fibroscan, is preferred. Liver stiffness greater than or equal to 12.5 kPa correlates with Medivir F4, ppV equals 92%. 6. Special tests. For patients with ALT 5 times ULN, rule out co-infection, HBV, HIV, and assess for autoimmune hepatitis, ANA, ASMA. Condition. Distinguishing feature, typical ALT, U/L, non-alcoholic fatty liver disease, NAFLD, metabolic syndrome, hepatic steatosis on US 3080, alcoholic liver disease, greater than 30 g/day ethanol, AST ALT, ratio 2, 40120, autoimmune hepatitis, ANA greater than or equal to 1 hours 80 minutes, IgG 2 times ULN, 150300, primary biliary cholangitis, AMA positive, ALP 2 times ULN, 2050 key points, anti-HCV antibody, sensitivity 99.5%, specificity 99.0%, OSLD/IDSA, 2023. Quantitative HCV RNA PCR, lower limit of detection 15 IU/ml, linear range 15100,000,000 IU/ml. Genotype assay, real-time PCR or sequencing, genotype distribution in U.S. baby boomers, 1. 68%, 2. 12%, 3. 8%, 4. 5%, 5. 6, less than 1%. Liver function tests, ALT normal range 756 U/L, AST 1040 U/L. Management and treatment. Acute HCV infection, less than or equal to 6 months, is rarely symptomatic. Most patients are managed expectantly. Immediate actions include key points, baseline labs, CBC, CMP, coagulation panel, HCV RNA, genotype. Counseling, emphasize abstinence from alcohol and avoidance of hepatotoxic agents. Monitoring, repeat HCV RNA at 12 weeks. Spontaneous clearance occurs in 1525. References. 1. Famsi et al. Use of electronic health records at federally qualified health centers, a potent tool to increase viral hepatitis screening and address the climbing incidence of liver cancer. Journal of Cancer Education, the official journal of the American Association for Cancer Education. 2021, 36. 51093-1097. PMID 322422302, https://pubmed.ncbi.nlm.nih.gov/322422302. DOI 10.1007/S13187-020-01741-1. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.